Chronic obstructive pulmonary disease. This includes chronic bronchitis and emphysema. The American Thoracic Society, which was founded in 1905, helps the world breathe. It's made up of pulmonologists, respiratory therapists, pulmonary nurses, critical care physicians, and sleep physicians. We'll look at some of the guidelines for chronic obstructive pulmonary disease, chronic bronchitis, and emphysema. Chronic obstructive pulmonary disease. Chronic obstructive pulmonary disease is a preventable and treatable disease characterized by airflow limitation that is not fully reversible. The airflow limitation is usually progressive and is associated with an abnormal inflammatory response of the lungs to noxious particles or gases, primarily caused by cigarette smoking. Although COPD affects the lungs, it also produces significant systemic side effects. Chronic bronchitis. The definition of chronic bronchitis is a chronic productive cough for 3 months in each of 2 successive years in a patient for whom other causes of productive chronic cough have been excluded or ruled out. Emphysema. The definition for emphysema is the presence of permanent enlargement of air spaces distal or at the end of the terminal bronchioles, accompanied by destruction of their walls and without obvious fibrosis or scarring. This shows 2 different types of destruction of walls. And we'll talk more about the different types of destruction that can happen in emphysema. In patients with COPD, doctors often call patients with COPD patients that have the characteristics of both chronic bronchitis and emphysema. However, the relative contribution of each disease is often difficult for the doctor to discern. It's hard to say that the patient is 50% emphysema or 50% chronic bronchitis. They're so intermixed. So the ATS definition of this is that for chronic bronchitis, it's all based on how they present clinically. For emphysema, it's based on pathology. Let's talk a little bit about the anatomic alterations of the lungs that are associated with chronic bronchitis. There's chronic inflammation and thickening of the walls of the peripheral airways. There's also excessive mucus production and accumulation, or lots of thick, sticky secretions that get stuck in the airways. There's partial or total mucus plugging in the airways, which can create smooth muscle constriction of the bronchial airways, or bronchospasm. Air trapping and hyperinflation may also occur in the later stages of chronic bronchitis. Now let's talk about the anatomic alterations associated with emphysema. there's permanent enlargement and destruction of the air spaces at the end of the terminal bronchioles. Also, there's destruction of the alveolar capillary membrane, or popped apart alveolar capillary membrane. There's weakening of the distal airways, primarily the respiratory bronchioles, and air trapping and hyperinflation. A little bit about how the disease happens and who it affects. It's estimated that between 10 and 15 million people in the United States either have chronic bronchitis, emphysema, or a combination of both, called COPD. Most authorities agree that COPD is underdiagnosed. According to Gold, our risk factors are incomplete. However, the following factors influence the development and progression of COPD. There are genetic factors: alpha-1 antitrypsin deficiency, also known as alpha-1 proteinase inhibitor deficiency, or A1AD, AATD, ATT deficiency, AP1 deficiency, and alpha-1 inherited emphysema is a genetic disorder affecting the lung, liver, and rarely the skin. Alpha-1 antitrypsin is made in the liver, and one of its functions is to protect the lungs from neutrophilic elastinase, an enzyme that can break down collagen in the lungs. When alpha-1 antitrypsin deficiency level is low, elastinase is free to attack and destroy the elastic tissue of the lungs. A severe deficiency of alpha-1 antitrypsin possesses a strong risk factor for early onset of emphysema, especially panacea emphysema. The premature development of emphysema is the hallmark of alpha-1 antitrypsin deficiency. Cigarette smoking significantly increases the risk factor for early onset emphysema in patients with alpha-1 antitrypsin deficiency. The normal level of alpha-1 antitrypsin ranges between 150 and 300 milligrams per deciliter, or 1.5 to 3.5 grams per liter when measured with radial immunodiffusion. Patients with normal levels of alpha-1 antitrypsin are referred to genetically as having an MM alpha-1 antitrypsin phenotype, or simply an M phenotype, or homozygote. The phenotype associated with severely low serum concentrations is the ZZ, alpha antitrypsin phenotype, or simply Z. The heterozygous offspring of parents with the M and Z phenotypes have an MZ alpha antitrypsin phenotype. The MZ alpha antitrypsin phenotype results in an intermediate deficiency. The precise effect of the intermediate level of alpha-1 antitrypsin is unclear. It is strongly recommended, however, that the individuals with this phenotype do not smoke or work in areas having significant environmental air pollution. Although alpha-1 antitrypsin deficiency is considered to be rare, it's estimated that 80,000 to 100,000 individuals in the United States have severe deficiency of alpha-1 antitrypsin. Age and gender. COPD increases with age. As a person ages, the risk for COPD increases. Although the precise connection between age and COPD is not known, it's suggested that it may be related to an accumulation of exposures throughout a person's lifetime. Also, COPD has been shown to be greater among men than women. However, more recent data seems to indicate that the prevalence of COPD between men and women is roughly equal, reflecting the changing pattern of tobacco smoking. Lung growth and development. Any condition that affects lung growth during gestation and childhood, such as low birth weight, respiratory infections, has the potential to increase an individual's risk for developing COPD. Exposures to particles such as tobacco smoke, occupational dust, chemicals, indoor air pollution, or outdoor air pollution all have an ability to increase a person's likelihood to develop COPD. Key indicators of chronic obstructive pulmonary disease in patients over the age of 40. The diagnosis of COPD entails documentation of symptoms or clinical indicators, risk factors, and the final confirmation of spirometry with the presence of post-bronchodilator FEV1 FVC ratio of less than 70%. Note, the above indicators are not diagnostic by themselves. However, the presence of multiple key indicators increases the likelihood of a diagnosis of COPD. A pulmonary function study is required to establish a diagnosis of COPD. This is data from the Global Strategy for the Diagnosis, Management, and Prevention of Chronic Obstructive Pulmonary Disease, which was revised in 2017 and retrieved from the goldcopd.org website. Socioeconomic status. Poverty. Poverty is clearly a risk factor for COPD, although the precise connection associated with poverty and COPD is not clear. Likely factors include exposure to indoor and outdoor pollutants, crowding, poor nutrition, and infection. The data strongly suggests that the risk factor for developing COPD is inversely related to an individual's socioeconomic status. In other words, the more poor, the more likely you are to develop COPD. The more money you have, the less likely you are to develop COPD. Asthma and bronchial hyperreactivity. Asthma may be a risk factor for the development of COPD. Chronic bronchitis may be a risk factor for the development of COPD. Respiratory infections. A history of repeated respiratory infections in childhood is associated with decreased lung function and increased respiratory complications later in life. Susceptibility to respiratory infections can lead to COPD development later in life. Also, tuberculosis has been shown to be a risk factor for development of COPD later in life. Key indicators for considering COPD in patients over the age of 40. Shortness of breath, difficulty breathing, chronic cough, chronic sputum production, history of exposure to risk factors, or family history of COPD. The three main spirometry tests used to measure severity of airflow limitation in a patient with suspected COPD are the FVC1, the forced vital capacity, and the FEV1 FVC ratio. Clinically, the FEV1 FVC ratio is also commonly called the forced expiratory volume 1 second percentage. The figure shown here illustrates a normal FEV1 and FEV1 that is typically seen in a spirometry of patients with mild to moderate COPD. The presence of a post-bronchodilator FEV1 FVC ratio of less than 70% is required to establish the diagnosis of COPD in the patient who also has key symptoms and risk factors associated with COPD. Gold recommends combining all above assessments so that the assessment of airflow limitation, which comes from your FEV1 and FVC, FEV1 FVC ratio, so all your PFT tests, which is your assessment of airflow limitation, and your assessment of symptoms, which can come from your MMRC or your breathlessness scale, or it can come from your COPD assessment test or CAT test, which I'll show you an example of shortly. And then also combining a risk for exacerbations. So that comes from your history and with your patient, talking to your patient that have they had 0 to 1 exacerbations per year or greater than 2. And so then grouping them by their CAT or MMRC score and how many exacerbations they have. And so this combined assessment, you'll use the tool for a combined assessment score. All right, let's take a look at that CAT test that you might use. This is an example of the CAT test, which is very simple. You can see that it's just a few questions that a patient can use either with help if they can't read. It comes in multiple languages, and it's super simple and very quick. So it's a scale, a Likert scale of 0 to 5, and it's very, very easy to score and very quick to do, easy to use for both the practitioner and for the patient. And it gives you an idea. The higher the score, the sicker the patient. The lower the score, the more well the patient is, and the less impacted they are by their disease. Additional screening methods used to diagnose COPD. Imaging. A chest x-ray isn't helpful to establish the diagnosis of COPD. However, it can be valuable in ruling out other diagnoses or establishing the presence of a significant comorbidity such as pneumonia, pulmonary fibrosis, bronchiectasis, pleural disease, kyphosis, and cardiac disease. CT scan can also be helpful in the detection of bronchiectasis or lung cancer in a patient with COPD. Lung volumes and diffusing capacity are a complete measurement of lung volumes and capacities, and airflow limitations can provide additional information concerning the severity of the disease. Measurements of the diffusing capacity, or DLCO, provide information on the functional effect of emphysema in COPD. A DLCO may also explain the breathlessness in some patients that appears out of proportion to the degree of airflow limitation. Oximetry and arterial blood gas measurement. Oximetry is common, it's non-invasive, and it is used to assess the patient's arterial oxygen saturation and the need for supplemental oxygen therapy. Oximetry is recommended to assess all patients with clinical signs that suggest respiratory failure or right heart failure. When the peripheral arterial oxygen saturation, or SpO2, is less than 92%, an arterial or capillary blood gas should be assessed. For example, an ABG of a patient with stable COPD could be a pH of 736, a PCO2 of 79, a bicarb of 43, and a PaO2 of 61. An ABG example that shows the patient in impending ventilatory failure or acute hyperventilation on top of chronic ventilatory failure could be a pH of 752, 52, bicarb of 40, and a PaO2 of 46. Exercise testing and BOD assessment, BOD index. Exercise activities such as the shuttle or 6-minute walk test are useful in assessing the disability of a patient and are used to measure the effectiveness of pulmonary rehab. The BOD index is used as a risk for mortality. Laboratory testing using a cycle or treadmill ergometry are useful for identifying coexisting or alternative conditions for such as cardiac disease. Alpha-1 antitrypsin deficiency screening is useful when a younger patient, such as less than 45 years old, presents with a history and clinical indications associated with COPD. A serum concentration below 15 to 20% of a normal value is highly suggestive of emphysema caused by AATD. The following clinical manifestations result from pathophysiologic mechanisms caused or activated by excessive bronchial secretions, bronchospasm, and distal airway and alveolar weakening. What will you see at the clinic the COPD patient's bedside? Heart rate and respiratory rate in stable patients. Normal vital signs. In exacerbations, COPD patients that are sick, you'll see increased heart rate and increased respiratory rate or tachypnea, a classic sign of hypoxemia. In chest assessment, for general body build, in emphysema, you will see thin, underweight patient, with irritability, digital clubbing, barrel chest, in emphysema. For the chronic bronchitic, or what we call a blue bloater, they're generally stocky, overweight. They have anxiety and irritability. Occasionally they have a barrel chest, and it's common in moderate to severe chronic bronchitis for them to have digital clubbing. In emphysema, they generally do not have cyanosis. They generally are pink, often called a pink puffer. They have reddish pink skin. They don't have peripheral edema or neck vein distension until very late stages, if at all, in end-stage emphysema. However, in chronic bronchitis, it's common for them to be cyanotic. That's why they're called their nickname is blue bloater. And it's common for them to have peripheral edema, be very puffy, and have neck vein distension. This is because of polycythemia, cor pulmonale, and an enlarged and very tender liver. With pink puffers in emphysema, they use their accessory muscles, and they do have a Hoover sign at the end, which is the inward movement of the lower lateral chest wall during each inspiration, and this indicates severe hyperinflation. In chronic bronchitis, that's uncommon. With the pink puffer in emphysema, generally they will have pursed lip breathing. They will not have a cough unless it's at the very end of life, and they will not have much secretions. For the blue bloater, they will have a cough, often most severe in the mornings, and they will have copious amounts of purulent secretions. When you're palpating the chest of a pink puffer, you may find decreased tactile fremitus, decreased chest expansion, and the point of maximal often shifts to the epigastric area. In the palpitation of the chest of the blue bloater is often normal. That point of maximum impulse often shifts to the epigastric area because of the hyperinflation in the pink puffer. Chest assessment findings for emphysema are percussion, when you're percussing the chest, or hyperresonance, decreased diaphragmatic excursion, again because of air trapping. And when you auscultate the chest, often hear diminished breath sounds, prolonged expiration, and diminished or muffled heart tones. With chronic bronchitis, you have normal percussion of the chest and crackles and wheezes. You may even have rhonchi. In moderate to severe chronic bronchitis and emphysema with an obstructive lung pathology, most forced expiratory volumes and flow rates will be diminished. Lung volume and capacities may be normal or diminished, but anything with the residual volume can be increased. In emphysema, a decreased DLCO is a classic diagnostic sign. The DLCO, usually in chronic bronchitis, is normal. At mild to moderate stages, an acute respiratory alkalosis from an increased respiratory rate is very common, with an increased pH, a decreased PaCO2, a normal bicarb, a diminished oxygen and oxygen saturation. Arterial blood gases, generally in severe stages, show chronic ventilatory failure with compensation. So it's a compensated respiratory acidosis with hypoxemia. The pH is normal. The PaCO2 is elevated. The bicarb is significantly elevated to keep the pH within normal range. The PaO2 and SaO2 are low. Acute on chronic changes should be watched out for in the event of exacerbation. It is the job of the respiratory therapist to be familiar with and alert for the following two dangerous arterial blood gas findings: acute alveolar hyperventilation, superimposed on chronic ventilatory failure, with possible impending acute ventilatory failure, and acute ventilatory failure or acute hypoventilation, not breathing enough, superimposed on chronic ventilatory failure. Both are life-threatening conditions. These are common oxygen indices with chronic bronchitis and emphysema in moderate to severe stages, as you can see. Hemodynamic indices in chronic bronchitis and emphysema at moderate to severe stages include central venous pressure, PA pressure, CVP pressure, cardiac output, laboratory tests and procedures. Hematocrit and hemoglobin in emphysema may be normal in the mild to moderate stage. They may be elevated at the late stage. However, in chronic bronchitis, polycythemia is common even in the early to late stages. Electrolytes in the late stage may show hypochloremia, and when chronic ventilatory failure is present, may have hypernatremia or increased sodium levels. Early and late stages for chronic bronchitis show hypochloremia, and when chronic ventilatory failure is present, show hypernatremia for chronic bronchitis. Sputum culture examination in emphysema usually is normal. However, for chronic bronchitis, it may reveal Streptococcus pneumoniae, Haemophilus influenza, or Moraxella cartiharis. Chest X-ray in chronic bronchitis, lungs may be clear if only the large bronchi are affected. Occasionally translucent or depressed or flattened diaphragms, and cor pulmonale is common. If a bronchogram is done, small spike-like protrusions may be present. Radiologic findings in emphysema. It's common to have translucent, depressed or flattened diaphragms, a long and narrow heart, and increased retrosternal airspace from barrel chest. Occasionally, cor pulmonale and emphysematous bullae are also seen. This is a chest X-ray of a patient with chronic bronchitis. Note the translucent or dark lung fields at the bases, the depressed diaphragms, and the long and narrow heart. This is a chest film of a patient with emphysema. The heart often appears long and narrow as a result of being drawn down by the descending diaphragm. Let's talk about how to manage COPD patients. GOLD provides an outstanding COPD management program that can easily be adapted to local care systems and resources. We'll identify and reduce exposure and risk factors to establish pharmacologic treatment algorithms and implement various non-pharmacologic treatments. We'll talk about management of both stable COPD and management of COPD exacerbations. Let's talk about management of stable COPD. GOLD recommends using the clinical data obtained from the combined assessment of the COPD rubric scoring system as a basis for developing a safe and effective treatment plan. This includes reducing exposure to risk factors. The identification and reduction of the patient's exposure to risk factors are very important. For example, cigarette smoking is the most commonly encountered risk factor for COPD, and when possible, smokers should be provided with counseling and smoking cessation programs that incorporate behavioral change, patient education, pharmacologic and non-pharmacologic intervention. In addition, efforts to have patients reduce their total exposure to occupational dust, fumes, gases, and indoor and outdoor pollutants should be addressed. Pharmacologic treatment algorithms and treatment therapies should be used to reduce the patient's symptoms and readmissions. These include decreasing the risk and severity of exacerbations, improving the patient's overall health status, and exercise tolerance. Some of the medications included in this are albuterol, Xopenex, Ceravent, Brovana, Atrovent, Spiriva, Duoneb, Anoro, Advair, Symbicort, Breo, and Dalaresp. These include short-acting beta agonist like Proventil, long-acting beta agonist like Ceravent or Brovana, short-acting muscarinics like Atrovent, long-acting antimuscarinics like Spiriva, combined SABAs and anticholinergics like Duoneb, combining LABAs and anticholinergics like Anoro, combining LABAs and inhaled corticosteroids like Advair or Symbicort or Breo, and phosphodiesterase inhibitors like Dalaresp. Non-pharmacologic treatments include things like smoking cessation, pulmonary rehab, vaccination, nutritional support, interventional bronchoscopy and surgery, monitoring and follow-up, and end-of-life and palliative care, and physical activity, as well, and education. Pharmacologic treatment algorithms shown here are based on Group A, B, C, or D classifications and are derived from the combined COPD assessment tool. These include inhaled corticosteroids, long-acting beta-2 agonists, and long-acting antimuscarinic agents. According to GOLD, an exacerbation of COPD is an event characterized by a worsening of the patient's respiratory symptoms that is beyond the normal day-to-day variation and leads to a change in medication. A mild exacerbation requires the initial use of inhaled short-acting bronchodilators, with or without a short-acting antimuscarinic bronchodilator. An example of this would be Combivent or albuterol. Albuterol is simply a short-acting bronchodilator. Combivent is albuterol combined with Atrovent. As needed. This shows protocols for treatment. Severe but not life-threatening exacerbations and the symptoms that indicate that severe and life-threatening exacerbation and indications for mechanical ventilator. A moderate exacerbation requires the use of short-acting bronchodilators, plus an antibiotic and/or oral corticosteroids. A severe exacerbation requires an ER visit, hospitalization, or a trip to the ICU and is associated with acute ventilatory failure. This is the end of my talk on COPD. Thank you for your time and attention, and I hope you'll come again. Have a wonderful day.